Rishikesh.
Ames Rishikesh. Okay. And Ames Madurai. Arumuganatham. Jyoti Ames Bilaspur.
Hi,
Eh?
Arun. Hello, madam.
Hello, Kishorji.
Hello, madam.
Good
Good
evening.
evening. Good evening, madam. Sorry. Arun, we can start.
Right, sir. Right, sir.
Thank
Uh, Good evening, one and all. It's my pleasant duty to welcome you all to today's meeting. And the meeting today has been scheduled on a very short notice, and we are going to discuss about the status of the UG and PG curriculum across all the institutes of national importance in the Department of Psychiatry. This meeting is being organized under the aegis of the UG and the PG Education Subcommittee of the Indian Psychiatric Society, and also under the banner of the Indian Teachers of Psychiatry Forum. I am Dr. Olgopal. I'm an assistant professor at the All India Institute of Medical Sciences, Kalyani, and also I am a STEPS awardee, which is one of the flagship programs of ITOPS in the past. It's my pleasant duty to welcome you all. Uh, uh, Now I will invite Professor Savita Malhotra, President of Indian Psychiatric Society, to kindly open the proceedings and deliver her short address. Thank you, madam.
you.
Thank you so very much, Dr. Arghya, and thank you, Dr. Kishorji, for organizing this. I must say the IPS, PG, and UG subcommittee, education subcommittee, PG and UG education subcommittees, the two subcommittees, along with ITOPS, Indian Teachers of Psychiatry Forum. Now, these three organizations put together through the year have done wonderful job and very great and very meaningful activities they have conducted in the last 1 year in terms of supporting teaching training in various areas like psychotherapy and various other areas. And today's meeting, where 22 aims in the country are together on one platform discussing, I am told, discussing the curriculum for PG today, maybe UG also, maybe later on, but all aims have you undergraduate teaching also in them. And in the country, we have 22 aims, and the heads of the departments or representatives of psychiatry departments of all the 22 aims are here today, as many as possible could be here discussing the curriculum, psychiatric curriculum in PG and UG. I think it's extremely important, time for us to rethink psychiatric curriculum. In psychiatry, we are now at a threshold point where psychiatry has changed tremendously uh, compared to the last 50 years or so, more so in the last 30 years. The last 30 years, there has been a paradigm shift, a sea change in development, in science, in neuroscience, in understanding and thinking about psychiatric theories, etiological hypotheses, and also approaches to treatment, and also thinking about patient care in general. See, earlier it used to be the patient care was hospital centric, was clinical, primarily urban, primarily symptom oriented, and primarily psychopharmacology based, and so on. Now, the psychiatric uh, theory has kind of undergone tremendous shift, a paradigm shift. I think this is time for us to rewrite curriculum. Rewrite curriculum. We are still teaching, and I'm talking about the content. I'm not talking of the teaching methods or assessment methods, which are also parts of curriculum. I will be focusing on the content and only the philosophy behind and what we teach and what is the philosophy, psychiatry philosophy that we teach to students, that has undergone tremendous shift. For example, the diagnostic systems. See, we are used to categorical diagnosis from DSM-3 onwards, categorical diagnosis. Now we have started talking about that these categories do not mean much. There is a tremendous degree of overlap. They are, interchangeable over a period of time. They are, there is a, as I said, overlap. Plus, at the basic genetic and molecular cellular level, there is a cross diagnostic overlap. So diagnostic categories do not mean really very much. So we have started talking about initially comorbidity, now dimensions, now spectrums, and so on and so forth. That is one thing. So we have to stop teaching our students in thinking categorically completely. That's, for example, one thing. Other things are the separation of mind and body. We had completely almost, delinked psychiatry from medicine. And now we know there is so much of overlap, and mind body interaction has to be involved, inculcated. Then is the brain and mind dichotomy. Our earlier teaching was focused primarily on mind, and we did away with almost brain and we were taught about the biological theories of mental illness only in terms of genetic and biochemical and this that, but we were not incorporating it in our uh, thinking about diagnosis. We were not incorporating these in thinking about diagnosis, because most of the theories were almost similar for all diagnosis, and so on and so forth. So now our thinking in neurobiology has completely changed. We are no more confined to neurochemicals or biomeans. We are talking of neural circuits and neural networks and so on. So thinking about the neurological or the neuronal dysfunction at the level of synapse or networks underlying psychiatric symptoms is something which we have to incorporate in teaching, which we are not currently doing. Similarly, our thinking was primarily oriented towards patients coming to us in the hospital, and we treat them. Now the focus has shifted to us going to patients, so in the community, and thinking in terms of community psychiatry and public health, not just clinic-based psychiatry. So, and then treatment methods. Again, there is a tremendous change. We have we had only we had psychotropics. Okay, so all the psychotropics, we thought they acted through neurotransmitters, but now we know that psychotropics have effects beyond neurotransmitters, and they impact the neuronal system, synaptic system, neurogenesis, neuroplasticity, and so on and so forth. And we are also developing newer treatment approaches which can kind of provide us with neuroprotection and neuro restoration. Restore abnormal neuronal functions, protect and the neuronal damage and synaptic damage and so on. So what I'm saying is that there is a tremendous shift in thinking about psychiatric etiological theories and treatment methods, and we have neuromodulation come in a much bigger way. Then another thing is our psychotherapy training is much more inadequate. Our training in rehabilitation and preventive psychiatry is inadequate. So our psychiatrists, as we train them, are very good clinicians, but they are not good. What should I say? Thinking in terms of system, public health, community psychiatry, leadership, and also biologists. They are not good as biologists, even neurobiologists. So I think it's time for us to rewrite our curriculum. Dr. Pratap is here. he is heading AIMS Delhi, and Delhi is the mother of all AIMS, 22 AIMS. What happens in Delhi perhaps can be easily followed, or will be followed in other AIMS. But if all AIMS that who are there, 22, get together, join hands, rewrite a curriculum for PG and UG, it will become a tremendous force. And I'm certain government and ministry or nobody will have anything, they will not be able to stop it. Also, I think the aims are autonomous, isn't it? Directly under Ministry of Health. So you can take your own decisions. You are not governed by NMC. Don't come under NMC. You are autonomous to that extent. So I think you have much greater amount of power. So you should all come together and use this opportunity. I was so glad to hear this, that this one particular event that is taking place today, that this is absolutely good and great opportunity. And after the PG, also please focus on UG. UG curriculums is far more important, will be much more impactful in terms of primary health, psychiatric care at the primary care level, mental health care at the primary care level. UG undergraduate curriculum will be far more important. So we have, on behalf of IPS already, again, I think you have given us a letter proposal for UG curriculum revision, which we have already sent to all AIMS, director, dean, and heads of the department. I don't know how many of you have got it, the letter from IPS about the UG curriculum. I would like to know that. It has been posted about 3 to 4 weeks ago. So again, we need to work on that also. And I would be very glad if this group, under whoever you choose as your leader, maybe AIMS Delhi, form a kind of a group, a joint action group. All of you come together and rewrite a curriculum. Dr. Pratap, please advise and guide and be the leader. I'm taking this liberty to request you, please, to rewrite the curriculum for PG. And also for UG, you only need to write a letter that let it be, their curriculum is written. That is fine. We don't focus on that. For UG, we only focus on making psychiatry as a exam question. So it may be spread across all professionals, like 2 questions in every exam. न्यूरोएनाटमी में 2 देना, न्यूरोफिजियोलॉजी में 2 दीजिए, बायोकेमिस्ट्री में दीजिए, फार्माकोलॉजी में 4 दीजिए, ऐसे करके या तो ऐसे स्प्रेड आउट कर लो, ठीक है, और क्लिनिकल में 2-3 दीजिए, और you make a separate question paper in the final MD, final MBBS. So for UG, you only need to write a letter, but for PG, please rewrite a curriculum, write a curriculum. It will be great. IPS can support you and be with you, and the entire IPS will stand with you. Or, so in this effort. But Dr. Rao is here in the next year under his leadership. If we are able to rewrite a curriculum and send it, to the ministry, that will be absolutely great achievement. And it should be then also homogeneous common curriculum for all. In many places, there are no written curricula. I don't know how many AIMS have written curricula still. And what are those? Are they uniform or are they different? We don't know. But anyways, I think it will be better for the country to have, at least in AIMS to start with, a uniform curriculum approved, agreed by all AIMS together. And IPS will provide all possible support that is required. Thank you so much, and my best wishes to you. And please keep me involved in, even though I will hand over charge, will not be president anymore, but in your work, I would be very interested in being, associated to see that our PG curriculum is revised and submitted. Thank you so much.
Thank you, thank you, madam, for your enterprising and encouraging words. And it was very enlightening for us to hear development, the way that the curricula has evolved according to your words, and we understand your concern that there needs to be a revision, and we will try and emulate what you have just said. Thank you, madam. It is now my pleasant duty to invite Professor T.S.S. Rao, Vice President of Indian Psychiatric Society and President-elect, to speak on this occasion.
Let me first wish all of you happy Sankranti and happy New Year for the this year. I am sure a lot of good things are going to happen. And at the outset, let me wholeheartedly put in place my consent to all the good work that has been started will be continued. That is one aspect. The second, see, for example, when we were doing, before joining PG, we were trying to look at the institutions. Almost always, AIMS used to be on the top. We should be there. In fact, we have grown up that particular way. And even today, if somebody has to talk about the gold standard, in fact, but unfortunately, one aims to another aims to other institution. There is a very wide gap is there, is actually which has been already acknowledged, and some mechanism to set it right has been started. That means first understanding situation and then implementing. This becomes much more easier actually. That is one aspect. I'll give you, before giving going to this thing, curriculum in general for UG, PG, one aspect of it. But there is something like there used to be a special section for faculty development used to be there earlier. Somehow last 2 to 3 years, this particular section has gone off. Why I am telling this point at this juncture is, see, I have been examiner. There are some institutions which are extremely good. There are some institutions hardly anything worthwhile in the sense that even there is no ECT machine. If this particular person trained becomes a teacher, not exposed, in fact, whatever type of curriculum is developed, not going to get implemented for the simple reason that these people are not ready. So I believe that there has to be what we call something like UG, PG, and other one to bring back faculty to sensitize them to the point that, in fact, say curriculum in general and maybe psychotherapy, what we are trying to talk about today to develop the curriculum, the relevance, importance, and training, and from that particular angle. In fact, I'll go one step ahead. I'll request Pratap Sharan to take care of this particular section which is going to come up. And I take it for granted that he is having the consent for this to see that we're all there, going to be there. And what actually has been pointed out by Madam will be definitely going to be fructifying in the coming days. I am more than sure that this is one of the very big achievement to get all these aims, that means all major issues at one particular platform. In fact, only very lucky people will see that all the aims people at one particular place. All aims heads to photographs to see at one point. Only very lucky people only can have that. All the best. Extremely happy that this has been set in motion, and we look forward to all the positive outcomes, and let us see that they're all executed appropriately at time to time. Thank you so much.
I think thank you. We should have all the visuals, visual picture of all the participants on the screen, and take a screenshot. Dr. Argepal, please. This is a momentous occasion. You don't realize the importance of this occasion. This meeting is very great. Everyone should,
Everybody should make videos on.
video on, please. Everyone. Yes. Nobody in hiding. So and take a screenshot. मुझे नहीं लेना आता, आप लोगों में से लेंगे और भेजेंगे भी मुझे.
Ajay.
Yes.
Hello.
Vishal. Mukesh.
Vishal.
Neelam.
Good evening, ma'am.
Hello. Hello, sir.
Good
Good
evening.
evening, Gurvinder ji. Yes, Dr. Mukesh Swami. Yes. So good to see everyone. We want to see everyone. Vishal, Dr. Neelam, कहाँ हैं आप लोग?
Actually, there is a problem with my camera.
कैमरे में प्रॉब्लम है? कोई नहीं 2 मिनट के लिए
Ah,
चलिए एक विशाल रह गए एम्स
Yeah, I'm
ऋषिकेश
taking
वाले
a screenshot.
रिचा स्क्रीनशॉट ले लेना ओके प्लीज कैरी ऑन
thank you so much. It is one of the very lucky day for all of us to see each other, and I'm sure the new year will be a great one. Thank you.
Thank you, sir. Thank you, sir, for your words and encouragement. We are really blessed to have that. Now, I'll invite Professor Kishore M., the man behind this whole mission. He has been instrumental in conceptualizing this, and I can tell you that this was conceptualized way back at the beginning of the year, and I was just fortunate to execute it. Sir will be speaking on the context of this meeting, and he will also set the agenda for this meeting. Thank you, sir.
Good evening, everyone. It's indeed a privilege to be part of this program. We were lucky that when the IPS made committees, we took it up very early. I think we were one of the first committees to start in June. And then we had a line of faculty who were very good in many different areas. And Dr. Agya Pral from Kalyani had already done a very nice survey of institutions of national importance. And his survey is one of the most quoted surveys, which says that the psychiatry faculty are interested in AIMS institution and they are keen and they want to be supported both for UGs and PGs studies. And we were keen, how do we encourage them to move one step ahead in terms of enhancing their experience in teaching, particularly when it comes to psychiatry teachings of undergraduates and postgraduates. What simple support can be provided to them in terms of resources, in terms of uniformity, and that's how this whole idea that we should bring all the AIMS institutions together. We believe that psychiatry teachers, irrespective of which AIMS they belong, they all have love for teaching and they teach undergraduates and postgraduates. And we know that AIMS usually attracts the best of best minds, both at the undergraduate level and at the postgraduate level. So involving the AIMS institution has a huge importance to the psychiatry field in India. And that's one of the reasons we thought that we requested Dr. Agya Pal to become a co-opted member of our committee at IPS and ITOP. And he was already an awardee and he had been trained in many aspects. So with the guidance of Dr. Pratap Sharan, we requested that we should have the meeting and involve all the people. And Dr. Agyapal was able to bring in board everyone. And we were lucky because IPS President Dr. Savita Malhotra, Madam, she was very keen that we should do everything possible. And Rao sir is already there. He has said that for the next year also, whatever it is required, he will stand by. So we were indeed lucky that the IPS leadership were keen to carry this exercise. And what we wanted is that undergraduate psychiatry, now we know that the good amount of information is available, both from the NMC document, which has made 2 certifiable skill. One is on the suicide risk assessment, another is primary care on depression. And it has allotted 40 hours of exposure for theory, 6 weeks of postings in undergraduate bedside clinic, and 2 weeks of mandatory psychiatry internship, additional 4 weeks of electives in psychiatry at undergraduate level. At postgraduate level, they have brought district residency program in NMC. They have added many other things in competency-based medical education. And as somebody rightly said, AIMS Rishikesh brought about mandatory evaluation for undergraduates. They were the first people and we should congratulate them. Dr. Ravi Gupta and other at the AIMS Rishikesh who made this possible. And I think another AIMS also made this possible. So whatever happens in AIMS,
Devgarh.
we get
AIMS Devgarh.
yeah, Devgarh. So it becomes implication for other institution also to incorporate best of strategies. So we need to know what we can do together, both at undergraduate and postgraduate level. So me and Dr. Agyapal, we felt that each institution should have at least 5 to 6 minutes, 2 to 3 minutes on UG, 2 to 3 minutes on PG. What is that they are doing and what should be done? So that collective document will become a main theme for us to come out with the consensus across the institution. And it over a period of time, all of us will do everything possible so that all AIMS institution faculty can be supported both at undergraduate psychiatry and postgraduate psychiatry. This is one of the goals. And this session, which will run for nearly 3 4 hours, all of you leisurely, please give your input and we will document your opinion because your opinion matters to us. And we will do as told by the IPS president and the president elect and Dr. Pratap Sharan sir, who kindly agreed to chair this session. So without much thing, I hand over to Dr. Agyapal. Thank you, Aro, for making this possible.
It will
Thank you,
go on for
sir.
3 4 hours today, Dr. Kishore?
Yes, ma'am. Each institution will have few minutes to say. So 22 institution will take little time, madam, but it is important for us to listen.
Yes, okay. I don't think, I thought initially if it was 1 hour, I'll sit through, but 3 4 hours
No, ma'am.
is
This
not.
is this is
So,
being recorded, madam. You will have access to it.
no, just listen to me. What I'm
Yeah,
saying is that you can continue with how
yeah,
the way you have planned and so on. But
yeah,
my request to the group is, Dr. Pratap is the chairperson today, and Dr. Kishore, you are in the
yeah.
lead role. My request to the group would be to come with a consensus on what do you think
Yes,
is
ma'am.
right or wrong with the
Sure.
curriculum today, number one.
Yeah.
Number two, that you need a uniform curriculum for the all the 22 aims, number two.
Yeah.
Number three, and rewriting the curriculum, form a committee who
Yeah.
should be tasked with rewriting the curriculum. Dr. Pratap can lead and assist and guide. And but then take on 3 4 people, volunteers or whoever,
Sure.
or
Yeah.
everybody, and make it a time bound exercise. Next 3 months,
Yes, ma'am.
नेक्स्ट
Yeah.
3 मंथ्स 3 महीने में एक रिवाइज करिकुलम लिख दीजिए एंड इट
Sure.
शुड बी रिफ्लेक्टिव ऑफ 21st century science behind psychiatry and mental illness, not 19th or 20th century psychiatry that we were taught or we have been practicing, we are practicing even today. So
Surely,
that,
ma'am.
okay, so
We
that is
will do
my,
it, ma'am.
yeah.
Our goal is to give it to you in this month itself, madam. We have in mind.
Wonderful. Wonderful.
Okay.
Thank
Okay,
you.
ma'am.
Thank you so
Thank you.
very much.
Thank you, ma'am. Thank you.
So I can take your, I'll listen to Dr.
Yes, ma'am.
Pratap, what he has to say, and then I will take my leave.
Yeah. Over to you, Dr. Pal.
Thank you, sir. Thank you, madam. Uh, I'll invite Sir Pratap Sharan sir to take over and speak on the topic. The agenda has been set by Professor Kishore, and I'll ask Sir to proceed with the question.
Thank you, Dr. Argo. I would like to thank Professor Savita Malhotra, Professor T.S.S. Rao, and Sir M. Kishore for giving me the opportunity. In this whole kind of development, I'm a late joinee in the sense that I have joined today, so I don't know about all the developments. Argo has given me a brief overview, but I don't know everything about what is going on. So actually, I had thought that I will listen to everyone else instead of giving opening remarks. I will give more like closing remarks, so that. But some of the ideas at AIMS Delhi, our undergraduate curriculum is pretty good. We don't have a final exam. In the exam, we don't have a separate paper. But other than that, compared to what the MCI has come up with now, we already have 9 weeks of clinical rotation for undergraduates. And from next year, we will have 2 weeks of internship also. 4-week rotation was always allowed. So in some ways, what the MCI curriculum has brought up now, we have more than that already in place. And we also have something called a gold medal for undergraduates. We have integration of undergraduate curriculum at the community medicine and at the community level. So there are many things which we are doing which are probably ahead of what West is doing in that sense. As far as the amount of time and the kind of training that is given, the place where we lack is that the number of marks that are there for psychiatry, despite the number of hours that we have, is very low. We have close to uh, about 8% marks in medicine. But interestingly, what we have managed to do is that we have 8% marks in medicine and we have about 8% marks in community medicine also. So on the whole, psychiatry kind of gets 16% marks out of all the final professional exam. At AIMS Delhi, the final professional includes CCM, the community medicine thing. So on the uh, we did not get marks in one place, so we got marks from two places. So in that sense, the importance of psychiatry kind of, and particularly public health psychiatry becomes quite important. Uh, in post graduation, at this point of time, we are revising the entire undergraduate curriculum of AIMS Delhi, including all the subjects, and psychiatry undergraduate curriculum is being developed alongside that. And there are certain things in the curriculum which we are emphasizing, like professionalism. We are emphasizing things like integration with uh, Indian systems of medicine and uh, 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 equity-based approaches to medicine, systems approach to medicine. So some of those things are getting included in undergraduate curriculum, which we had not done earlier. Uh, uh, in the new revision that is taking place at this point of time, it's almost settled as far as one subject remains, the rest of it is already settled. Uh, in uh, in that it's going to be a very integrated curriculum with the rest of the departments, and the focus is a bit that we should be teaching undergraduates what undergraduates need to learn rather than psychiatry the way postgraduates need to learn. So a lot of effort has been made to make it more undergraduate friendly. So we are focusing more on priority conditions rather than teaching everything in psychiatry. And uh, the second thing that we have done there is that we have separated the knowledge and skills SLOs so as to focus more on the skills. Otherwise, they tend to get overlap occurs. So that's something that we have attempted there. This year in post graduation, our curriculum is it's a written curriculum, but not a very kind of uh, it's not based on CBMEs, for example. So this year we revised the curriculum. Now it's written, and uh, it's a bit more on competency based, but till now it's not it's not a very great curriculum. So the postgraduate curriculum definitely needs a major revision even at AIMS Delhi. I think I'll just leave it here because I did not really know what I was supposed to speak today. I'll prefer to listen to what other people have to say, and then maybe I can respond to some of those things. So thank you for giving me the opportunity to be here, and I will be happy to help in whichever way the committee wants me to.
Thank you, sir. Thank you for at least giving others also a template because I understand that this meeting was called in a very short notice. So many of them, and it's not easy to present curricula in a very short span of time because it's such a multifaceted entity in itself that giving it a structure and presenting it in terms of what's good and what's bad may not be very easy. But still, we got a very important feedback from you, and engineering New Delhi is always a benchmark for all the other institutes in the country. It's also said that education is a progressive discovery of our own ignorances, and that is with that attitude we will proceed with the other stakeholders for this meeting. And at the onset, I will admit that I may not be familiar with all of you. So maybe at certain point of time, I will be addressing you by the name of the institutes, and I beg your pardon for that at the onset only. It's now my I have received a request from IIMS Bhubaneswar to go ahead, and with the permission of the chairperson, I allow that. I request Professor B.R. Mishra to come forward and present the status of the curriculum.
Yeah, good evening, madam, and good evening, sir. Good evening to all of you. Now, we would like to mention regarding what is being followed here at AIMS Bhubaneswar. Now, I was told to tell about the teaching hours and the clinical posting hours and the mark pattern during the exit exams for UG. So for UG, we have theory classes. We have total of 40 hours per batch for one batch over 5 years. So this 40 hours will be spread over 5 years. For this clinical posting, we have 90 hours of clinical posting, which will be spread over 5 years. So the clinical posting they have in the second year, in the third year, and in the fifth year, and the final year. And every year they have this 2 weeks posting, 2 weeks posting. So total of 6 weeks posting over 5 years. So we can discuss about increasing the clinical posting duration if everybody agrees to. And third is the mark in the medicine paper 2. We have actually 20 marks for psychiatry in medicine paper 2. So related to the kind of inputs, number of classes, hours being given, and the marks, it looks there is a subtle discrepancy. So we can discuss about the possibility of increasing the marks, assessment marks in the final exam. In many places, they have after the posting is there, they have an end posting exam. We don't have this end posting exam here at AIMS Bhubaneswar. But if everybody agrees, then we can have a uniform policy which can be adopted across all the medical colleges in terms of the duration of clinical exposure or clinical posting, the end posting exam, and views regarding the mark that should be there in the medicine paper 2. There was a discussion shortly with the ministry also related to, there was a committee related to this suicide related, some steps are being taken as per the directive of the ministry. A committee is there which is framing some guidelines. So there a suggestion was made whether psychiatry should be made a separate subject because it will create awareness and it will have some preventive effect. We had a discussion among the colleagues, and all of us unanimously felt that introducing psychiatry as a new subject, as a completely new subject, may not be a very good idea in terms of reduction of stress. Rather, it will add to the stress. Rather, we encourage that something in terms of gatekeeper training, mandatory gatekeeper training related to suicide and substance use should be encouraged, and at the end of the training a post-session assessment can be done, and it should be mandatory for all. Like we have a biostatistics program mandatory, so this is something which can be mandatory for all. So these are our views related to UG program. And for PG program, we have the teaching hours is 450 hours over 3 years, spread over 3 years. So every year we have 150 hours. And we have 3 academics per week. This is a standard thing which is followed in many places. Plus, we have the special posting. For addiction, we have 3 months. For child and adolescent psychiatry, we have 3 months. Then for clinical psychology posting, we have 1 month. Neurology posting is 1 month. Many places, like we have also seen our candidates, and many places we have also visited. I feel there is a need to increase the neurology exposure. By the time frame of exposure in neurology can be increased, and some assessment can be done at the end of the posting to increase the neurology quality. We would also advocate that now, since the era of neuromodulation has come, so neuromodulation training for 10 hours, including classes and hands-on training for 10 hours, can be thought as a possible as something which can be thought, can be incorporated. Many places EEG is something which is taught in many places, so EEG knowledge will be an additional thing. For 10 hours of EEG classes with hands-on training. Similarly, interpretation of neuroimaging CT and MRI brain, this should be there for 10 hours. So these things can be incorporated. And the psychotherapy, like many places, we have 20 hours of supervised psychotherapy, which is being followed. We recommend that it should be increased to, it can be increased to 25 to 30 hours under the supervision of the faculty. So these are the suggestions from our side, sir. Over to you.
Thank you, sir, for the insights. And we have duly documented. We will now proceed to the representative from AIMS Bhopal, Professor Vijender Singh.
Yeah, thank you, Arjo, for giving me this opportunity. And big thanks to all the uh, executives of the committee, Dr. Rao sir, Madam sir, then Dr. Pratap sir, for taking up this humongous task of reviewing the curriculum. And I think for UG, yes, there are some things which can be done. If I can talk about our hours for our UGs in our institute, uh, surprisingly, we have 5 weeks of posting during MBBS for psychiatry. So that's where we have that, means I would say the edge, because since I joined here, since that time, the MBBS posting for psychiatry has been 5 weeks. So that's one thing which I wanted to share. The rest of the things like for theory, yes, we have 52 weeks. That 52 hours, yeah, that's one. So we have two sets of theory classes, one during the 5th semester, second during the 7th semester. And clinical posting is during the 7th semester largely. Yeah, for internship posting, it is 2 weeks only. That's what is, I think, NMC pattern. So that's about the UG, and as Dr. Snehil also part of this ITOP platform or committee, so he has been actively involved in utilizing all the methods of teaching, like small group learning, right? OSCEs. So all kind of teaching methods we have been trying for providing the skills to the UG students who are posted with us during ward posting. That's what is about. Yes, and one more thing. During exams, one of our faculty does go to the general medicine and as a part of general medicine final exam, we also have a table. So 10 marks of practical and 10 marks of the questions. So 20 marks, that is the contribution of psychiatry. But good part is that, yes, during the practical exams, one of our faculty is there to examine practical part for psychiatry. Definitely, it's different from that being done in the AIMS Rishi case, where they also invite external faculty. That's a plus point for them. But here in our institute, we don't invite external faculty for psychiatry. It's only our department faculty which goes to the general medicine to conduct the practical examination. That's what UG is. About PG, I think we are largely following the AIMS Delhi pattern, and some improvements as has been given by the NMC of late. So all those things we have kind of included of late. So for PG, I don't think there is means something different, but for UG, yes, we have some edge over other institutes. This is what from my side. Hello.
Thank you, Dr. Vijender. I think Argo has probably gone out of the.
Yeah, I think he has gone out, and I would request next somebody to start.
Doctor, from AIMS Kalyani, maybe you can start.
Hello, I will represent Orgo sir since he's with AIMS Kalyani only. Sir, what we have discussed more or less, AIMS Kalyani is also following more or less AIMS Delhi curriculum, and minor modifications we have made. In the UG thing, sir, we have done one thing, that we have included marks, 20 marks in theory, also 20 marks in the Viva of medicine. It's included under medicine. So in the 20 marks, we don't give cases, but we have case-based vignette is there, case vignette is there. On that basis, we ask questions. This for UG. And also we have a tray where we have some EG waves, we have medicines, where like a spotter kind of thing, and the marks are divided in 10 plus 10 in the Viva. Theory also we have short questions, not long questions. We have 20 marks, 5 marks, 4 questions we have in the medicine paper. So this is how we are doing UG. UG, so mainly lectures, what Mishra is told around, I exactly don't remember the time, but around 30 to 40 hours. And case discussions, 2 weeks of posting they are having, undergraduate. However, they are coming twice. One, they are coming the third semester, and that is too early. But since early clinical exposure is there, that time they are coming. And another time they are coming in the eighth semester, in the final MBBS. So this is the UG part. In the PG, sir, what we have done, we have a structured academic schedule. We have case discussion, workup, IPK, all these things are there. Since we have various subspecialties in our institute, like CAM-HS, child adolescent psychiatry, addiction psychiatry, we have a good neuromodulation facility. So we post them around there. Also, we have psycho-oncology, like we also have a liaison with oncology, and we have a psycho-oncology clinic. So we post them there. Also, we send our PG for NIMHANS posting. Neurology is definitely there. We have 1 month neurology posting. And NIMHANS, we send them for forensic medicine and I think neuropsychology. So also we have incorporated, sir, one guest faculty in psychology who comes and have 20 hours per semester classes, theory classes in psychology. So she's an experienced one. So PGs get benefited mainly in the first year. All PGs, however, attend, but we have made it like that. It's mostly in the first year where psychology has, and the final year where they learn about therapies and all. We also, sir, have psychotherapy discussion rounds. It's in the morning where we have psychopathology and psychotherapy. So in the morning 8 to 9, this is divided. The days are divided where we have alternate psychotherapy or psychopathology discussion rounds. So in the exam, we have one thing we have introduced apart from long case, short case, neuro case. We have another thing that we have introduced of a managed case. Means a PG who has seen a case and had a follow-up for that. During his or her posting, we had to present that case, and it's like a case discussion where already a case is known to the PG, and it's like then the questions will be asked regarding the diagnosis, the management strategies. So this is one thing that we have introduced. I think that is not there in the other areas. Otherwise, most of the things are, I think, whatever we have discussed. What I have seen, sir, in many places, since we are talking about uniform curriculum, many places, sir, ECT is not being given. In West Bengal, I am saying many places where postgraduate courses are being run, ECT is not being there because we get a lot of patients for ECT referrals. Then this RTMS neuromodulation, which are now an upcoming advancement in psychiatry, those things are not available. So if we have a curriculum, then we have to think where these PGs will go for this training. Either then like AIMS Kalyani, AIMS Bhubaneswar, those places will have overcrowding of PGs coming for training for ECTs or neuromodulation. That part I think has to be taken care of if you are including this in the curriculum. Apart from that, IP care also should be there. I think where PG is there, every institute should have IP beds, which is definitely lacking in many of the institutes, sadly to say. So I think before making unified curriculum, we have to discuss all these issues, and then we can take a call, sir. Thank you, sir.
Thank you.
Thank you, sir. Apologies, I lost my internet and I haven't been able to get it back. Thank you, Sukanta sir, for representing IMS Kalyani. I'll now move and I'll request Dr. Shantanu from IMS Deoghar come forward and present the status there.
Thank you, Orkhoda, for this opportunity, and I thank and wish a good evening to everyone senior to me and colleagues. So I'll be presenting a brief about how the undergraduate curriculum and the postgraduate curriculum works in AIMS Deoghar. We are a new institute which started to function in 2021, and as like AIMS Rishikesh, AIMS Deoghar also has a separate subject. The psychiatry is a separate discipline in the third professional part 1. So coming to the UG, normally we had the board of studies done in presence of 2 external experts in November 2024, and theory classes totally we have around 80 hours of 70 to 80 hours of theory classes in the term of didactic lectures and small group discussions and everything, which are spaced into 2 different broad headings in terms of theory classes and tutorials. So tutorials are done on alternate Tuesdays for 2 hours. In those tutorials, we normally divide into half an hour of didactic lecture, followed by 1.5 hours of some degree of intervention, some degree of, for example, demonstrating catatonia, or in terms of case vignette, a small group discussion to discuss about how to manage a patient with dementia, with behavioral and psychological symptoms, or delirium, or regarding basics of neuromodulation, like what are the indications of ECT and etc. Application of skills, doctor-patient relationship, and so on and so forth. So total we have around 70 to 80 hours of theory classes spaced in the 6th and the 7th semester. Regarding clinical posting, we have total 6 to 8 hours of clinical posting for 3 hours each day. So that is spaced twice, once in the 6th semester and once in the 7th semester. In 6th semester, we have 4 weeks of clinical posting, and in the 7th semester, 4 weeks of clinical posting. That amounts to around 8 weeks, and that is for 3 hours on each occasion, to total 24 hours of clinical posting. So coming to the exam, we have 3 formative exams and 1 summative exam. So 3 formative exams, we have one in the mid 6th semester, one we have at the end of the 6th semester, and the pre-professional exam that is at the end of the 7th semester. So these are taken by the Department of Psychiatry. And apart from the mid 6th semester examination, the other examinations has both 100 marks of theory paper and 100 marks of practical evaluation. And the summative exam is of 200 marks, that is 100 marks of theory and 100 marks of practical, in which we invite 2 external faculties who come along with 2 of our internal faculties who take the examination in different batches of the students. And students are awarded different marks in the third professional part 1, apart from ENT, eye, CFM, and even orthopedics is a separate subject in AIMS Deoghar as well. Regarding internship, students has to have a mandatory 15 days of posting in psychiatry. So we get in rotation 2 students, 2 interns for a span of 15 days. And they are posted both in the clinics and also in the neuromodulation for ECT and TMS services. Some of the important innovation that we have done is that since we were involved in tobacco control with the Department of CFM, one project we had done with international funding, we have tried to incorporate the module of tobacco control and cessation for a 6 hours training, mainly in liaison with the Department of Community and Family Medicine in terms of horizontal integration that we have done, and that is mandatory for the 6th and 7th semester students. And along with that, we have twice yearly gatekeeper training for suicide prevention. So that is about the UG teaching. Regarding PG teaching, AIMS Deoghar has been a recent entrant into PG teaching. So currently we have 2 students and the 3rd student is about to join in this current INI-CET in January end. So it is spaced around 6 semesters, and normally the teaching learning method that has been used is didactic lectures for the initial few weeks regarding to psychopathology training, for initial 4 to 6 weeks, like basics of thought, mood, perception, disorders of self, and etc. Followed by integrated lectures are being done, and then it has been spaced after 3 months It spaces to like twice weekly seminars, journal club, case presentation, bedside round, and once weekly grand rounds. So normally it becomes a 2 to 3 weekly event for postgraduate student. And from 2026, we have started a psychotherapy discussion a module that would be happening once a month on the third week for the postgraduate student. That would be a 2 hour session. So that would be both for psychotherapy in the terms of CBT, ERP, some degree of nuances of third wave psychotherapy, and also in the terms of assessments like assessments of intelligence, assessment of personality, so on and so forth. We don't have a clinical psychologist, so normally it becomes a interactive session with the students, so on. Regarding external posting, AIMS Devkar is currently having a talk with the executive director and the dean academics so that we can send the students outside. It is still in the formative stage, and since we lack a dedicated clinical psychologist and a proper department of neurology, we had been instrumental in liaising with CIP Ranchi to send the students for these two postings there, but still we haven't got any formal feedback regarding this. And we have neuromodulation, both bi-weekly ECT we could give, and we have this TMS facility that is given daily basis, 2 patients per day, and JRs and SRs are posted for both these neuromodulation techniques. Thank you.
Thank you, Shantanu, for apprising us about the situation at AIMS Devghar. I'll now invite Professor Gurvinder from AIMS Bhatinda to talk about the situation at Bhatinda. Welcome, sir.
Good evening. I'm really grateful to thank the IPS UG and PG Education Subcommittee and ITOP for convening this timely discussion. I wish you everyone happy Lodi and happy Makar Sankranti. It was very wonderful to listen to Professor Savita Malhotra, Professor Rao, Professor Pratap Sharan on a very, very important topic. So we have to discuss why we as psychiatry today stand at the intersection of growing mental health burden, changing mental health education framework, increasing societal expectation from medical graduates. So as faculty from institutes of national importance, we carry responsibility beyond our institution. So various psychiatric disorders, every medical graduate, irrespective, especially encounter depression, anxiety, suicidality, substance use disorder, delirium and behavior emergency. Psychiatry is therefore not optional, but foundational to competent medical practice. So as everyone was talking about the undergraduate, so fortunately or unfortunately, when I joined at AIMS Bathinda, there was no MD course. So we started MD course and one seat was allotted to us. So there were, we in theory, we were given 40 hours. But there was a medicine department faculty was less. So that increased to over 70 hours. We went to Dean Academic many times, sir. हमें 70 से 80 hour are given, so that is too much. We should be have 40 hours, but that trend still going on. And our lecture is at the 8 a.m. You see, so much winter is there. So 8 to 9 a.m. first lecture is of psychiatry. That is also on Saturday also. So we have discussed with the authority, but the solution was not there. So in the clinical posting, there were 4 weeks of clinical posting, and the examination. One very important exam there is send-up examination. In this medicine department, people during send exam, they also internal assessment is there. We are given 20 marks for theory and 20 marks for practical. That is the internal assessment. In the final examination, again, we are given the 12 marks in the theory and 12 marks in the practical. I myself go to the exam center and we justly give case dignity, and the student takes so much interest in this way. As far as one of the speaker was talking about the gatekeeper training, so that is a very, very essential. We have taken the help of Safdarjung Hospital and Dr. Pratap Sharan and give gatekeeper training to all the mentor and mentee, and it was a very successful experience. So suicidal tendencies of the students, we have adopted a screening instrument at the time of admission, so that has been very helpful for us. As far as the postgraduate is concerned, so we just adopt the AIMS New Delhi pattern. So their academic posting is there. So we have also community posting of the resident, because if you come to the Bathinda, Bathinda is known for Bathinda Kent. So the whole army area is there. We got so many requests from the army areas and rural background. Send your some senior resident or junior resident. So we have also 15-day posting at the Batinda camp, and that approach is very helpful for us in both way. Now we are getting so many requests for other places. The other fortunate is that we have got successful in getting DM one seat of this psychosomatic medicine recognized from our general body and other. So we have DM one seat, and so in the Punjab, you come to this addiction is a big problem in this area. We are also trying some DM starting addiction psychiatry. So mostly we follow the pattern of AIMS New Delhi, and I'm very grateful to everyone. We must unite together and make some group. We should also meet in NCP also. So the NCP is coming on from 28th to January. We should meet together and regularly. So we some institutions are very in neuromodulation, some are in psychology. Unfortunately, we have to do MOU with our institution. For example, I requested Dr. Pratap Shan to help in psychology training. He helped us a lot. But there are issues of MOU with other institutions. If we work together, all head of department, we can do lot of work. I'm really grateful to RSL and Dr. Pratap Shan for giving us this opportunity. Thank you. Thank you very much.
Thank you, sir, for your insights. I'll now invite. I believe Dr. Jyoti Gupta is there from IMS Bilaspur. I will invite Madam to talk about the situation at IMS Bilaspur.
Good evening, everyone. I have prepared a PowerPoint presentation. Shall I share it?
Absolutely, Madam. I can share the screen.
Is it visible?
Not yet, Madam. It is now visible. You can make it full screen. I think.
Okay. So we are three faculty over here. Myself, Dr. Jyoti Gupta, Dr. Bhupendra, and Dr. Neelam Kumari. And for MBBS teaching, we have been allotted about more than 50 hours of for theory. It has about 35 hours for lectures and 16 hours for tutorials or small group discussions or seminars. We make the students present symposia. We divide the topic into groups among groups, and then among the students, and ask them to present the symposia. And the hours have been distributed in 6th, 7th, and 8th semester. And we have two postings of 2 weeks each in clinical postings, which are in 4th and 8th semester. Usually the case-based discussions are there. And after that, we have a ward living after each posting. We have been given 1 to 2 lectures in foundation course at the admission of the MBBS students, and some integrated teaching is also done. We have been teaching with pharmacology, forensic medicine, dermatology, medicine, neurology, and OBG. And in internship, there's 2 weeks of posting, and there we make them present a seminar. And regarding the elective postings, till now we have not been given any elective postings. It was the postings were given in the major department, major subjects. The option has been asked for posting this time, and we have given the option of consultation license psychiatry and addiction psychiatry, and they are saying that they would permit 7 students each. Regarding the PG teaching, we don't have any separate ward and OPD postings, and GR stays in the ward days a week, twice a week at daytime, and there is no separate consultation license posting. It as was proposed in the curriculum, it was for 3 months in 3rd semester, but the JR is involved in the on-call duties weekly basis. I mean, we have clubbed the JR with the senior residents, and they are seeing the on-call. They are on-call duties there in emergency as well as ward. and this is JR is being supervised by SRO faculty. And community psychiatry was proposed in fourth semester in the curriculum, and we are planning to start once a week community visit by the JR in supervision with SR or the faculty in urban training health center, rural training health centers, and open air jail is also there. We have a lot of patients from there. We are also planning to post once a week, once a month to the jail. Neurology, we have proposed 2 months of posting in fourth semester. We had proposed psychology posting of 1 month in the curriculum, but we are not keeping the RJR in the psychology since we have only one JR as of now. Forensic psychiatry, we had proposed in the curriculum. But this JR was supposed to be posted in the mental hospital at Shimla, Himachal Hospital for Mental Health and Rehabilitation, for about period of 1 month. But we are having adequate exposure of MLC cases here also, so we are thinking that it can be we will not move ahead with this posting. And we have proposed 3 weeks of posting of child and adolescent psychiatry at PGIM at Chandigarh. We are in process of taking the permission for the same, since the CAP services are not fully established in our institute. Regarding the teaching hours, these are the seminar, journal club, and case conferences once a week, tutorial case-based discussion twice a week, and CPC and departmental patient care audit are on rotation basis of the all the departments, and thesis work presentation 6 monthly. But we are not able to do all the academics on weekly basis, since we have a shortage of JRs and only 2 SRs are there, but we have 1 academic per week. And during the first year of residency, a JR is supposed to attend UG psychiatry classes. And yearly exam, we have formative assessment we have practical and theory exam, and 6 monthly EPA based assessment of the JR, and also we have multi-source feedback and maintenance of logbook of academics is also there. So further, we have the proposal that we may start 1 to 2 weeks posting each in nuclear medicine and radio diagnosis, neuromodulation posting, and psychosomatic presentations in collaboration with Department of Pediatric Neurology and Medicine, and psychotherapy supervision groups we are planning to start with. That's all. Thank you.
Thank you, Madam, for the comprehensive overview. I'll request you to stop sharing your screen. Thank you, Madam. We will now proceed to AIMS Gorakhpur. Richa, Madam, maybe there.
Good evening, everyone. Sorry, my camera is not working, so you will have just to listen me. Really sorry for that. So, AIMS Gorakhpur, the Department of Psychiatry, was established in 2019, and currently we have both OPD and IPD setting. So, the hours of posting for undergraduate psychiatry, we have undergraduate psychiatry clinical postings in 3rd semester, 5th semester, 6th semester, and 8th semester, 2 weeks each at a time. So, a total of 2 months are allotted to psychiatry clinical postings during undergraduate. However, for theory, it is only in 6th semester, and we have been allotted 22 hours of theoretical posting for psychiatry. We also have integrated theory classes with other specialties for undergraduates, such as pediatrics, gynae, or forensic medicine. We do conduct a ward leaving viva during the end of each semester posting. In internal examinations, we do not, psychiatry is not as a separate subject, but it is a part of medicine at AIMS Gorakhpur. So in internal exams for final year, we have 15 marks for theory and 10 marks for clinical case. And for the professional examination, total 10 marks are there. What extra we are planning to do is we have also planned psychiatric assessment for the first year MBBS who are newly joining the institute, and that will be eventually followed during their clinical postings at 3rd, 5th, 6th and 8th semester. For postgraduate psychiatry, we are running the postgraduate course for last 3 years, and currently there are number of junior residents in Department of Psychiatry at AIIMS Gorakhpur are 7. So we have 2 theory classes per week. We have postings in general psychiatry, OPD and IPD throughout the course. In addiction psychiatry, particularly in the addiction treatment facility clinic, the junior resident is posted for 2 months. We do not have a separate child and adolescent clinic, so during the whole curriculum, the exposure to child psychiatric cases are done. We have 2 months neurology posting in the institute only. For psychology posting, we have contacted with KGMU Department of Psychiatry, and so the residents are sent to KGMU Department of Psychiatry for their psychology posting. We have also rotation-wise postings of the junior residents in neuromodulation therapy, such as ECT and RTMS, and the junior residents also have a trauma and emergency posting for 1 month. For teaching and learning methods, clinical ward rounds, clinical discussions, presentations, including seminar, journal club, case presentations, tutorials, teach back sessions, and even, are done. We have also planned once in a month on Saturdays a movie club, after which assignment is given that what they have can they rephrase the findings of the movie or what they have learned from the movie. Formative assessment for the junior residents is done every 6 months, which includes both theory exams and case presentation with Viva. So in AIIMS Gorakhpur, for undergraduate, psychiatry is not taught as a separate subject, but rather as a branch of medicine. We feel that the marks allotted to psychiatry is also too less, and considering the ADCOM model which is currently proposed by the NMC, good communication is an essential skill for a doctor, so we do think that psychiatry should be included as a separate subject in undergraduate. So this is all from my side. Thank you.
Thank you, madam. We will now proceed to AIIMS Guwahati, but I believe we may not have any representation from the institute. Do we have anybody from AIIMS Guwahati? We will then proceed to AIIMS Jammu. Do we have anybody from AIIMS Jammu as well? We will then proceed to AIIMS Jodhpur. Dr. Mukesh will be there to talk about. Welcome, sir.
Thank you, Dr. Arya. Good evening, everyone. So, most of the things I think we have similar as AIIMS Gorakhpur, AIIMS Bhopal in UG teaching. We have theory lectures in 6th semester mainly, but other than that, we have Saturdays are usually logged for integrated teaching and unconventional learning. So for these, we have almost 20 hours of teaching across all semester. From 3rd semester onwards, we have few unconventional learning. And then after 6th semester, subsequently, we have integrated teaching. So overall 20 hours are dedicated to in these two areas. So overall 40 hours of theory teaching is there for UG. Other than that, clinical postings we have in 5th semester, 3 weeks posting. In 6th semester, again 3 weeks posting. And in 8th semester, 2 weeks posting. Assessment part is done in semester examination, 8th semester examination and 9th semester examination. We have questions of psychiatry within the subject of medicine, second paper. And in final examination also, in theory, we have 10 marks for psychiatry questions. And in practical also, we have 2 stations in practical examination of 10 marks again. Other than that, we also contribute to the internal assessment for MBBS students through the marks of ward living assessment in 6th semester and 8th semester. So this was for the UG teaching. in PG teaching, structure is almost similar. I will just highlight the things that are slightly different from other centers. For teaching, we have theory lectures, 2 lectures every week. Then, other than that, we have posting of our resident in some specialty areas, like once a week, our resident goes to the integrated pain clinic, which is run primarily by the critical care medicine and PMR department. Then we have resident posting in community clinic. Then we have CL psychiatry posting for 2 months in 4th semester. Then in ATF also we have 2 months posting. We also post our resident to the disability certification. Whenever there are patients who are coming for disability certification, residents also join faculties for those administrative purposes. Other than this, we also have a regular psychotherapy forum once in a week. So in this, we have divided our department into 3 groups, which have faculties, senior resident and residents. And we usually discuss the psychotherapy cases, at least 2 cases in one session we usually discuss. So resident present case as well as they present the formulation and plan for their therapy. And the discussion is done within the group and to improvise overall care of the patient and competency of the residents. So these were few things. I have few suggestions as well. First, regarding the UG teaching, I think as Kishore sir has highlighted that there are 2 competencies defined by NMCs right now. NMC right now. One is in suicide prevention, and the other is the management of depression in primary care. I think we need to define at least 5 to 7 competencies in psychiatry. And those competencies should not be related to the subject of psychiatry per se, but how psychiatry is likely to contribute to the competencies of a medical practitioner as a whole. For example, there are certain areas that a medical practitioner must know. One is the management or assessment of psychiatric emergencies, because these are the cases they frequently see in emergency setting and also in a general medical setting also. Then assessment and management of common mental disorders, substance use disorder, which frequently complicate all medical and surgical situations. Then delirium management, and finally pain and palliative care, which is again an upcoming area with increasing burden in palliative care. Again, psychiatry has an important role to play in that. So these are the areas in which probably if we impart knowledge and develop competencies of a medical graduate, it will be more useful for them as well for the society and overall medical profession. So contribution will be more rather than focusing on the core psychiatric aspect like psychotic disorder, bipolar disorder. That may not be that much useful for them. So the proportion may be changed a bit. Core psychiatry may be 40% and 60% of these areas. Just a suggestion that we need to define competencies more cautiously, looking into the mind that what we are targeting. We are targeting UG students in that matter. Regarding PG, also I just have 2 suggestions which I think are useful to improve overall experience of the resident per se. One is there should be some defined competencies for residents as they progress through their residency. For example, in first semester, they should have some competence that they are supposed to achieve, then second, third semester, and maybe in final semester. So we cannot expect similar level of competency to all the students. What happens sometimes, the first semester residents are given some psychotherapies and they are obviously not that much competent. So that can affect their confidence level as well as how they engage with the other curriculum and other things. So maybe defining competencies as per semesters, defining expectations as per semesters will improve their own experience of this residency. Second, I think we have talked about or discussed about psychotherapy in past few months a lot. So in psychotherapy also, I think psychotherapy training has improved a lot. There are psychotherapy forums, psychotherapy discussions are also there. But again, the assessment of psychotherapeutic skills is not done, I think, anywhere in India. In any center, I think psychotherapy skills are not assessed properly. Other than this submission of certain hours of psychotherapy, like we have 100 sessions of psychotherapy mandatory for appearance and examination, but that doesn't measure the skills of a resident. It's more of a clerical kind of thing. So we can formulate some measures on which psychotherapeutic skills of a residents can be measured. So the training in psychotherapy can be improved with this. So these are a few suggestions from my side. Thank you all.
Thank you, sir, for the suggestions, and they have been duly noted. I'll now invite Dr. Thinmozi from AIMS Madurai uh, to speak. And I believe also Dr. Arun Gunathan is also there in the meeting. So both of
Yes,
them are
sir.
representing AIMS Madurai.
Yes, sir. Thank you, sir. Can I share my screen, sir?
Yes, madam. It is visible, madam. You need to unmute yourself.
Sir, I'd better go, sir. Sir, I'd better go with the presentation, sir. Sir, am I audible, sir?
You are audible, madam. You can share your screen.
Madam, if it is not possible, please proceed.
Yes, sir. Yes, sir. I will do that, sir.
Yeah.
Sir, though we are working from a temporary campus, we are making sure that we provide an inclusive psychiatry training. So we have only undergraduates. We have 5 batches of undergraduate students, a total of 250 students. And regarding the overview of undergraduate teaching hours, we have a total of 41 hours of lectures, which includes student symposium and integrated teaching with the Department of Pharmacology, Forensic Medicine, and Community and Family Medicine. So lectures, we have 32 hours of lecture classes, 5 hours of student symposium, and 4 hours of integrated teaching. And we have a total of 96 hours of clinical posting. So in total, we have 137 hours. And regarding the semester-wise distribution, uh, we start our psychiatry training from the 3rd semester. We have 10 lecture hours and 2 weeks of clinical postings. In 4th semester, we have 2 hours of integrated lecture with pharmacology department. In 5th semester, we have 1 integrated teaching with the Department of Forensic Medicine, and we have 2 weeks of clinical postings. In the 6th semester, we have 18 lecture hours and 3 hours of student symposium. In the 7th semester, we have 2 weeks of clinical posting. And in the 8th semester, we have 4 lecture hours, 2 hours of student symposium, and 1 hour of integrated lecture with the Community and Family Medicine Department. Regarding the nature of our clinical postings, we focus on bedside clinics, DOAP sessions, skill stations, stimulated patient encounters, case-based and problem-based learning, role plays, as well as debate. As Dr. Pratap sir said, we focus on core clinical subjects, along with training on ethics and breaking bad news. And regarding the status of elective posting, we don't have a separate elective posting in psychiatry, as psychiatry is a mandate core subject. And regarding the exclusive innovative endeavors, we start our psychiatry training as early in the 3rd semester from psychology. And we have a student symposium, we have narrative and case-based teaching, and we focus more on gender inclusive and culturally sensitive competencies during the clinical postings. And we also emphasize on mental health advocacy, reducing stigma and discrimination, and also rights of persons with mental illness. And we also focus on positive mental health and dedicating an exclusive module on positive mental health during the 8th semester. And regarding the assessment, we have internal assessment under general medicine department 3 times, one in the 6th semester, one in the 7th semester, and one in the 8th semester. And we have one pre-professional exam in the final semester. And by the end of every clinical posting, we have an end posting assessment. And regarding the summative assessment, we have 25 marks for psychiatry under general medicine, which has 5 MCQs and 4 short notes. Right now, we don't have a PG, we don't have post graduation, but in future we would like to incorporate neuromodulation, observership in established INIs, licensed psychiatry, and of course we want to focus on gender inclusive training. That's all from my side, sir.
Thank you, madam. I will request Dr. Adu sir to speak if he wants to speak something. We will then proceed to IMS Mangalagiri.
We would like to put in an idea of like why go for a single summative assessment rather than go for a 3-year long assessment happening, so that it is fruitful. So the student also participates throughout the training program. So thank you for the opportunity.
Thank you, sir. I was supposed to invite Dr. Vijay Chandra from IMS Mangalagiri now, but sir has expressed his inability to join the meeting due to unavoidable circumstances. We will now proceed to IMS Patna, and I'll request Dr. Pankaj Kumar to present. May I request Dr. Pankaj Kumar from IMS Patna to present? I believe sir will require some more time to come forward. May I request Dr. Shruti Sinha from IMS Raebareli to present?
Yeah, I can join. Am I audible?
Yes, madam, you're audible.
Yeah. Good evening, respected teachers and other faculty members in INIs. I appreciate the efforts of IPS, Indian Teachers of Psychiatry Association, for gathering all of us together and requesting feedback as well as possible solutions. Just to give an introduction, we have both UG and PG teaching at AIMS Raebareli. This institute was initiated in 2021. Dr. Argya himself was a part of this institution, and we also have neuromodulation in the form of ECT as well as RTMS. Again, courtesy Dr. Argya, I would say. We have been running the PG program since 2023, and our first PG is about to roll out in the next semester. Our pattern of teaching for UG students is that we have lectures of 42 hours, which is distributed only for the third year, that is the pre-final year. But we are able to have one lecture per week for the entire year. For clinics, we now have 2 batches coming, which is the pre-final as well as the final year, which are posted for 2 weeks at psychiatry. And additionally, there is an 2 weeks posting for interns. So in total, the MBBS students have a total of 6 weeks of clinic posting at psychiatry. Due to a lack of stable faculty members, we have not been able to conduct ward leaving tests, but it is in our forthcoming plan that we are planning to have ward leaving tests for all our UG students. We for lectures and clinics as well, we try to deal with the priority areas like Dr. Pratap and other senior members have suggested that we have to have a separate pattern of teaching for UG as well as PG students. So for UG students, we give them a basic idea of the major psychiatric disorders. We give them, since we have specialty clinics running, we give them an exposure to addiction medicine, child and adolescent clinic, and the recent initiation of women's mental health. So they do have an exposure to the OPD sessions, but the teaching is basically for the basic psychiatric disorders. We also ensure that whenever a relevant case is there, these UG students do get an exposure of neuromodulation in the form of ECT or RTMS, whichever is being run. Apart from that, they do have elective postings as well, which we run in the specialty clinics. So one is for the child and adolescent clinic, and one is for the addiction medicine clinic. So these children, they come for elective postings for this in these two areas. Unfortunately, the medicine exam has allotted very less marks for psychiatry, and that is one area which we have to work on. And also the suggestion of having psychiatry as a separate subject, which might take a longer time in institutes like us. And for that, I would request that if it could be done in a phased manner, because it is not possible for all institutes to immediately implement psychiatry as a separate subject, but definitely it is a need of the hour. Also, like someone mentioned about the other meeting about suicide prevention in all the aims. So we are getting a boost in that direction as well. We are running foundation courses for not only MBBS but nursing students and all. So we do get lectures over there, and we have to, it is in the plan that we have to have lectures for positive mental health again. So although that is not a part of curricula, but that is something that we are, which would possibly help with the UG teaching as well. Apart from that, regarding the PG teaching, we have now, earlier we used to have 2 sessions per week. Now we are improving, and we can have 3 per week. So the teaching goes in the form of tutorials every Tuesdays, case conferences every Thursdays, and seminars every Saturday. So that is the pattern we are running. We have a compulsory 6-month thesis assessment, and also every 6 months we do conduct examinations for our PG students, both written as well as practical examinations. Their teaching is in the form of clinical rounds. Definitely OPD exposures are there. We also ensure that all our PGs get exposure to ECT, RTMS, and psychotherapy is one area I'm trying to inculcate teaching. Unlike others, I would like to mention my parent institute, KGMC, had a regular pattern of psychotherapy group meetings, which I'm trying to initiate in my institute as well. And we used to allot certain cases to the PG. So I would like to suggest that to other INIs as well, that we could at least do basic psychotherapy if we have a presentation of sort, just like we have a case conference. If we include at least once a month psychotherapy group meetings, then they can at least have 4 to 5 sessions of psychotherapy done, and we can discuss on how they can be improved. So that is one thing I think all of us can adopt. Regarding specialty, right now we are not able, I mean, we could not due to administrative reasons, but we now have permission to send our PGs to other institutes as well. So maybe like other institutes, we could send them to NIMHANS or other INIs for areas where we are not able to cover. Other innovations which we try to do is, we try to ask our PGs to have an innovative thinking of their own, not just spoon feeding by us. So all PGs have to do their case workups and have a diagnostic plan ready. And we encourage them to suggest what treatment to start and how to approach, and then we give our feedback. The other innovation which we are trying to have is having movie clubs and book clubs to increase their interest in the subject as such. And that is something which has been appreciated by our PGs very much. So we plan to add more of that in the futures. We are lacking SRs right now, but as soon as we are about to have more of them, so probably we could involve them more in the teaching process and have a better exposure for our PGs. One suggestion which I would like is, if since we have all of us have collected here today, we have a lot of other platforms running like Brain Wednesdays and Thursday Musings, and Dr. Pratap Sharan is running the Cyrex program. If we could have a common online platform where our PGs could maybe once a month collect and present a case, because one thing we are lacking here is all three of us are we are all assistant professors. So our PGs lack the kind of feedback they should get from senior professors. So if we could have a common platform where one of us could take a case every time, that would be a very good help for our PGs at least. So that is something. And regarding neuromodulation, since we have the machine here, I would suggest that we could have workshops, like someone was telling that there is a crowding of PGs at one place. So we could have, if not posting as such, we could have workshops in separate regions, like we could cover nearby AIMS Gorakhpur, AIMS Patna, Devgarh, whatever we can collect, and have workshops for training in neuromodulation. And thereafter, we can have it on a regular basis in 3 months or something like that. So those are the suggestions from my side. And I would appreciate others' feedback for improving our curriculum as well. Thank you very much for giving me this opportunity, Dr. Argya. And thank you to all seniors for collecting all of us. Thank you.
Thank you so much, madam. It's very heartening for me to listen about updates from IMS library. Thank you, madam. I'll now request Professor Pankaj Kumar from IMS Patna to present the situation from Patna. Thank you.
Good evening, everyone, and sincere thanks to organizers and Pratap Saran sir to taking this initiative, and it's a need of the hour also. So begin with regarding the MBBS course part, mostly we are having 6 weeks of total clinical postings of MBBS students, which is divided into two parts. First one posting happens of 4 weeks in the second prof, and the second posting happens in the third prof part 1, which is called. So in that, so total we have 6 weeks of clinical posting, which includes 3 hours of clinical exposure every day, in which we are divided into 3 parts. Predominantly, one is the clinical bedside skill development, another is the case demonstration, and third one is the OSCE based frequent weekly assessment based on whatever. So, and at the end of the posting, we do the end posting assessment also, which includes not only these 3 weeks of posting summation, but also we have in Viva also, which is included in that. And all these internal assessment marks goes to medicine, as it is under the medicine, not a separate, and that is also combined together while calculating the internal marks of the medicine as a whole. So psychiatry's internal assessment proportionate combination appears in their internal assessment. That is related to the clinical posting aspects. Related to the theory and lecture classes, we have total 40 lecture classes allotted. All these lecture classes happen during the third professional, part 1, phase 1 and phase 2, both mixed together. So this is the predominant main this part. But apart from that, we have also one provision of elective posting of 1 month in the final part, phase 2 of the MBBS, where every year we have different themes. Like 1 year we did the theme of addiction psychiatry, another year we had the anxiety disorder, another year some other common mood disorders, predominantly based on the aspects of the like Nimans has been doing into the primary care psychiatry training aspects, because the ultimate goal, which my some previous colleagues also talked about, apart from the all the large competency which has been there in UG curriculum of psychiatry, the core basic goal of IMD is in the IMG is at least they are able to identify, give the basic treatment, and also able to handle the basic psychiatric emergency, and should be able to understand when to refer and where to refer. So these aspects we are able to deal specifically during the elective posting part. So far as the practice of integrative teaching is concerned, that in practical is not happening, largely because of the lack of the policy of the institute in that direction, and also because there are still not very willingness on the other departments part to be into horizontal or vertical integration. So this is another important challenge. But one thing, another important aspect which we are doing in MBBS is, apart from the foundation course of ATCON, in which our department is actively involved, apart from that, we are also doing stress management and mental well-being, taking care of mental health and well-being for first year MBBS students. 4 different classes are allotted into the earlier 3-4 months, so that helps at least patient students to get sensitized also. So apart from that, the regular student wellness related activities, which has now started and picked up more faster in last 1 year, in that also I have felt that now people are more forthcoming about their own problem. So through that, their sensitivity and their awareness is increasing, and people are more and more coming into the elective posting. Earlier, it was one student or two students out of 125. So now we are getting 780 students. They are voluntarily coming for elective posting. So that part I found it very useful to be done in that. So far as the exam part is concerned, in the final MBBS, it comes under medicines. We have only 14 in theory part in medicine paper 2, which is only short questions, and 14 into the practical aspects, which happen as told by other earlier colleagues. There is one station for psychiatry, in which we keep all the case vignettes and the basic some medications, and there are certain instruments basics which we have been talking or teaching them, and based on that we do the clinical assessment, and these are included into their final prof marks also in pre-prof and prof. So that is the all about the MBBS course. For MD courses, it is almost being run on the pattern of, I'd say, AIMS Delhi mostly. The only thing is that since we are still not having the enough space, infrastructure, and the manpower also, we are only 4 faculty. So the posting, separate dedicated posting to CL or to child or to addiction or to this, what we are dealing it, that every unit, we have divided 4 faculties as a 4 units. Each unit, apart from the general psychiatry, they are dealing with specialty. One unit is dealing with child, one unit with addiction, one unit with geriatric psychiatry, and also we have one neurodevelopmental clinic in association with psychiatry. So in that way, the PGs are rotated to the different units monthly. So they are getting overall good exposure in all these things. Regarding the somatic treatment part, yes, our ECT turnover is very, very high, and that helps them learn the somatic. And related to the other neuromodulation, yes, we are not having that facility, and that's a major limitation of the PG's training, because it is a very upcoming, but very soon it is coming up. And related to what can be done in the regular to improve and uniformalize PG training particularly, I think there is One suggestion related to we should have competence into the semester by which my earlier colleague, and these competencies should be developed into three categories. One into the clinical skills, another should be research skills also, because that is an important mandate of MD training. MD training is a very, very important research. And the third is the community psychiatry or community outreach, because that is the very, very important part which is significantly lacking, community and forensic. But we are posting them for 2 months at NIMANS. We have MOU for community and forensic psychiatry. But that doesn't help much so far as the improvement in skills and getting more and more trained. It's just a orientation and sensitization. So these are the points which I would like to add for the PG training aspects. For UG training, many people have talked about separate subject, but in my view, I don't think separate subject is going to serve the purpose of catering to the larger treatment gap or the service gap. Rather, the things like what we said, mental wellness related more and more activities, more integrated policy based teaching and training methods. The more it is included, the more there is vertical and horizontal integration, then more people will be more aware and sensitized. And this elective posting can be one important good thing which can stimulate at least some MBBS students who are more oriented. They can take up in early part the important steps towards taking the PG into the psychiatry. So this is all I have to say towards my side. Thanks you. Thanks.
Thank you, sir. We got to know a lot about the status at AIMS Patna, which is one of the older AIMS. I'll now request Professor Vishal Dhiman from AIMS Rishikesh to present the status about at that place.
Thank you, Dr. Orgo, for giving me opportunity. First of all, I would like to thank Dr. Sharan for giving me the opportunity and taking this opportunity. And this is a very important time to actually, there are many aims now and INIs are increasing, number is increasing, and it's very important to think about this very important topic. So I would also like to thank Dr. Rao and Dr. M. Kishore and Ma'am Malhotra Ma'am. So Dr. Argo, can I share my screen?
Yes, sir.
Okay. Are you able to see?
It's visible, sir.
Okay. So at AIMS Rishikesh, we are actually 6 faculty members. So as it has been told by Dr. Kishore that we started at AIMS Rishikesh this psychiatry as a major subject and assessing it separately from general medicine and allied sciences. Actually, it started in 2019 when we started psychiatry as a major subject, and we started to teach it as separate subject and started to do an assessment. We had a national workshop for undergraduate curriculum of psychiatry, which was organized by us under the aegis of IPS in 23-24 September of 2019. And there were members of IPS with ample experience in UG teaching from all zones. They were approached by us, and those who attended were Professor Kishore, Professor Rajat Ray, Professor MV Ashok, Professor OP Singh, Professor Chadda, Professor Mohan Isaac, and many others who attended this. What we did is actually we allotted them broad topics, and they were asked to develop a preliminary list of subtopics and competencies, as well as specifying the suggested teaching and assessment methods. And then what we did is we collated the list. We had a roundtable discussion and deliberation on each topics. So what we all, after the discussion and deliberation, I am sure Dr. Kishore must remember that the outcome was that the duration of the training, at least 40 hours of theoretical training should be there for psychiatry in MBBS. At least 4 weeks of clinical training should be there. At least 2 weeks of training in internship, and psychiatry should be examined as an independent subject during MBBS. And it was also reiterated that undergraduate teachers development program should be organized in support with IPS, which is happening right now. So these were the members who attended this program. So what now currently we are doing at AIMS Rishikesh since 2019 to 2020, what we are doing currently in MBBS in our dual exposure model. So I can see that few of the new aims, I guess Bilaspur said that, and one more, Gorakhpur. What like us, we are posting our undergraduates twice in psychiatry. Our first posting happens in third semester, which is in second prof. It is there for 15 days, at least 2 weeks of posting is there. What we do is, it is important for their foundational understanding, and it helps them to have an opportunity for spiral learning and early clinical confidence. And then what we do is a skill based learning is there. They go to the clinical areas and then learn the basic screening assessment skills. We do not teach them like theory, we do not teach them much, but it's important for them to have a basic clinical understanding and a gist of what psychiatry is. And then the main posting happens in the third prof, which starts in sixth semester, and at least for 4 weeks, which is 30 days of clinical posting, is mandatory for them. So they learn all the things like advanced case management and treatment planning and clinical decision making. And about the theory of MBBS, the core lectures in sixth and seventh semesters happen, and we faculty take around 35, minimum 35 hours of lectures, which means a lecture of 1 hour means 35 lectures in whole of this sixth and seventh semester. Uh, and then we also have a provision for integrated teaching modules, which are 5 modules we have prepared, and these are interdepartmental collaboration with departments like medicine, gastroenterology, physiology, biochemistry, and many others. And they count up to 10 hours. It helps those the students for long term retention and bridges the isolated knowledge with clinical reality. And now something about the assessment, how we do that. It's a multi-modal assessment, as other aims are also doing, and it reflects a continuous validation. It includes the formative as well as summative assessment for them, and it is equal weightage, which means that 50% internal and 50% is external. So there are end clinical postings, which are skill assessments based on OSCE, OSPI, and OSLers. We do pre-prof for MBBS, like a rehearse for stand-ups for their final profs. And in final profs, we have a separate exam where we have four examiners, two internal and two external. So for each batch, we have a separate exam. And now, as Dr. Sharan has said, that he has around 8% of marks as part of the general medicine subject, we have around 10.25% approximately, which is 46. But they have to pass the psychiatry independently. Failing psychiatry blocks general medicine final exams. So which means that we see it as a strength, not a hurdle to them. But we do not provide these marks as a separate psychiatry subject in the final mark sheet to have actually uniformity with the INIs and NMC or national guidelines. We have many other publications based on this model we started, and we also try to take the students perspective when we ask them, few of them, that did it improve your knowledge compared to your colleagues, did it change your perspective of psychiatry, and if yes, how. We have all this data available with Indian Journal of Psychiatry, and it is very encouraging. Recently, I have seen in September 2025, there was a report, recommendation, which is trying to do what is trying to recommend a uniformity in medical education in new aims, all new aims. under the chairmanship of Dean AIMS Delhi. In this, I can see that they have recommended 135 hours of total psychiatry training, which should include at least minimum of 54 hours and 81 hours. So I would say that at least this much should be there in our curriculums. We are doing much more than that, but they have reduced. I don't know why the clinical part, but theory they have increased. Now, what is happening in our institute regarding the PG academics, it's mostly the same which others are doing, like case conferences, seminars, journal clubs. The most important thing which we are doing is actually the 50% of the same, the equal weightage is given to the formative and summative assessment, so that one bad day in the external exam doesn't mean that a person's daily or internal assessment actually is very important. So what we do is, for theory we do end semester 5 exams we take for them, which includes long questions, short questions, performance based questions, and MCQs also. And we do a pre-prof exams. Day to day assessments are done in exam, in seminar, journal presentation are marked, thesis progress and update evaluations are marked, and then their publication preferences are given to their thesis related publication is also marked and included in the internal assessment. And practical also in the internal we do end semester practicals, and then log books and day-to-day assessment, their case presentations are counted toward that. And final exam is similar to what is happening to all other aims. So my suggestion is, as others have already talked about, the psychotherapy training. So I suggest that now we are moving toward the biological model more, but I think it is very important to learn the psychotherapy also. Dr. Shah is taking very good initiative about a group which he is running, and it's happening, but it should be included in PG teaching, I think. So this is what I have to say about. Thank you.
Thank you, sir. And listening from IMS, Rishikesh is obviously very enterprising, because it was one of the institutes that had a lot of innovation in this field. Uh, Over the course of preparing for this meeting, I have made a few mistakes, and obviously I have missed talking about AIMS Raipur. But unfortunately, Dr. Ajay, who was representing AIMS Raipur, could not stay back for the meeting any further. We could not also gather opinion from a few other institutes, that includes AIMS Nagpur, AIMS Rajkot, and AIMS Jammu. And AIMS Guwahati, I have received comments from a few faculty members from there, but they are not in a position to present it in the forum right now. They will give us their written feedback later on.
Dr. Argo,
So,
sorry to interrupt. This is Dr. Sarah. I
oh,
just
okay,
was able to join. Thank you
okay,
so
okay, okay.
much for your patience and your kind
Dr.
understanding.
Sharad is right,
Yes, sir.
right, sir. Please, please.
Good evening to everybody. So sorry, sir. I am not able to turn my video on. I'm on my way back from Nagaland. We had gone for the NMHS validation, and I'm in transit, sir. So this is like a very august gathering, and I think this is a very pertinent we're all discussing. Very happy to contribute and hear about the role of psychotherapy and the things that we are doing to improve psychiatry education. My HOD could not take out time. This is our vacation period. A few, we are quite. Since we've started PG training only in the last 2 years, and we now have a final year's batch. We've started our psychiatry training from 2022 itself. We have had one batch which has finished their final profs, and they're just completing their internships now. Initially, we were following the AIMS Bhubaneswar curriculum. As has been mentioned just by the previous speaker also, that they had a very good curriculum in terms of greater clinical exposure. And so, unfortunately, what has happened is uh, after the first batch graduates, we are allowed to change the curriculum, MBBS curriculum of the Mentor Institute. So they have also undertaken a change, and the number of clinical hours has reduced. the theory hours have increased. So this is as regards UG. So with regard to UG things, we find that the batch sizes, they are a big limitation, especially when we consider lived experience as part of the motivation for someone to take up psychiatry. There are many who would like to discuss in depth or have a more detailed discussion. There is definitely a dearth in the time or the opportunity to engage in such discussions. So, one thing that has been a limitation for us is the batch sizes. We are getting 4 clinical batches, roughly about 22 to 25 in size. So, many a times we are lost in, in delivering the clinical hours also as like a didactic case presentation sort of a discussion thing. So we are looking at what we can do to improve on that. Uh, at this point of time, psychiatry is considered within medicine part B exam, and we are accorded a little less weightage compared to dermatology in the last exam. We had contributed some questions, and then from there it was picked up and then taken up for the decision by the exam setters. So that's something which was out of our control, but we would like to see more than the formative or more than the summative assessments. If we could include more things with relation to attracting people to psychiatry. Frankly, one of the things that people are telling us, there's either it is too complex to understand or it is just too simple. There are lots of simplistic, euphemistic phrases. ये तो सब कुछ मन में ही है. They just have to stop thinking like this. These are the explanatory models that our medical students also possess, especially when we get a feel of this, especially when we are taking sessions for them or trying to provide some guidance for them, especially with regard to their well-being. So we have to break a lot of models and stigma and all of that as well. So I'm not sure if we're doing enough for that, and we're still trying to incorporate all of this into the same age-old curricula duration which is there, and we're trying to add more things. Like now there is Ayush. Now they are discussing some of these things in physiatry, in physical medicine and rehabilitation as well. As well as the separate hours that they're getting for psychology and allied sciences as well. So that exposure to psychiatry, it seems to be getting diluted. One of the things that we are hoping to do is try and expose during clinical hours more towards neurostimulation, brain stimulation techniques. So we've just got our RTMS, and we've started ketamine, TDCS. The same machine also is able to deliver some of the other modalities. So trying to kindle the interest research and trying to give some putative models, brain-based models for behavior and behavioral disorders also helps in some way. So we're just trying to examine that, and we will be including that in our clinical postings as well. As regards PG, we're still experimenting with regard to how we can motivate for greater academic interest. One of the big challenges that we are seeing is that PGs do not have a specific accorded time for research in their work. Actually, the conflation of being a resident as well as resident doctor as well as being a learner does take time for them, and so that's one issue which is there. We're just trying to work that out and see what we can do towards kindling more interest. We're also trying to add more conferences and see, trying to particularly identify interest early on and kindle some working towards that. I just have these thoughts. Sorry if I have droned on too long. Thank you so much. Back to you, Dr. Argo.
Thank you, sir. It was very nice hearing from you. That probably concludes the initial presentation of all the institutions. I'll just reconfirm whether I have missed anybody, and uh, that would be absolutely inadvertent if I have missed, but I'll just confirm. Have I not invited anybody to speak? If that is it, then this opens the ground for further discussions from the amount of information that we have gathered. Professor Sharan, I'll ask you to take over.
I think it's a discussion which has been going on. So, anyone wants to add something to or respond to something that has been spoken by other people?
Sir, I really say that it was a very nice discussion. If you see comprehensively, we are on the same platform. We have to more discussion like that. So whether undergraduate or postgraduate, some curriculum like some similarities, some more bringing together, more discussion, that will be very fruitful. So this should not be the one only one meeting. So it should go on. This is my humble submission, sir.
Thank you. Anyone else wants
Sir,
to respond?
this is Shantanu from Devghar. Sir, one input was that as Vishal sir from AIMS Rishikesh has rightly put forward that the recent committee is planning to merge psychiatry again with as a minor allied subject with general medicine. So yesterday in AIMS Devghar we had this stakeholder meeting with all the departments in which Dean Academics of various AIMS has put forward the upcoming curriculum in which psychiatry will lose its separate status and will be merging with general medicine along with dermatology, and ENT, eye, and orthopedics will be merging with surgery as allied subjects. So in that case, psychiatry has been given 80 marks, dermatology 80 marks, and medicine 240. And this examination would be for psychiatry and dermatology would be taken at the end of the 8th semester. And for the ortho, ENT, and ophthalmology, it would be a 60 marks paper. So somehow downgraded for them as well. And they would be taking the exam at the end of the 7th semester. So like there is a dichotomy here. Like we are putting forward to keep psychiatry as a, we are advocating to take psychiatry out and giving a separate status as what Rishikesh and Devghar currently has. But what the committee has decided, and they are inviting stakeholders' comments for this for further deliberations, is regarding merging. So we need to be, we had a discussion in the department as well. And like I couldn't give a feedback to the Dean Academics as of now because I was looking forward for this meeting. What should we look forward and do in the next course of action, sir?
As far as this group is concerned, I think you should give the opinion that it should be a separate subject. On the whole, I think most people feel that it should be a separate subject. And as Dr. Dhiman had mentioned, that there was this meeting that they held at Rishikesh, which had, there were a lot of educators together who suggested that it should be a separate subject. So as far as giving the suggestion is concerned, I don't think there is much of a doubt. Whether that suggestion will hold water is a different thing altogether. Because there you are competing with a lot of other subjects. And there is you have to convince people who are not psychiatrists to be able to get that. But if you are given the chance, obviously you should emphasize.
Sir, I want to add something.
Yeah.
first and foremost is that the National Medical Commission wants to move towards the national exit exams. It's called the next exams. And one of the important things at undergraduate level we wanted to emphasize is 15% of the national exit exams should be given to psychiatry, which aligns with what you said about 16%, which you said. So approximately 15% of the national exit exams in whatever format the government and the National Medical Commission wants to take it, the weightage should be for 15. That's one aspect, 15% overall. That's one thing. And to defend that, we should forward the National Mental Health Status, National Mental Health Survey. But more importantly, we should repeatedly tell from the National Task Force on Mental Health that the doctors across India have said very high mental illness among undergraduate and postgraduates. We should use that and repeatedly convey that if you cut or reduce, it is going to adversely affect the mental health of doctors. And this is the survey which supports that we should do it. That would be one aspect of it. Second, we should not come down on the hours of exposure of psychiatry. That is 40 hours of exposure of psychiatry at undergraduate level. We should not come down on it. And 6 weeks of psychiatry postings, which the NMC has already accepted, we should not come down on 6 weeks of psychiatry postings, irrespective of where they place it, first, second, third, and fourth year. And mandatory 15 days postings in internship also is something we should not give up. And we should give logical reason, evidence base. That is one aspect. The second is, as long as the current curriculum is concerned, we should encourage the NMC model where there are at least 2 certifiable skills. One on, they have said in depression, every MBBS doctor should have a certificate saying that he has been trained to manage depression in primary care. And second, the suicide risk assessment. I think that is logical. We should really consider that as certifiable skill that every MBBS doctor should do. Suppose the institution gives more opportunity, more certifiable skills can be added for each institution. That is one way of looking at it. For example, somebody wants substance use as the first thing. They can use for nicotine or alcohol as one certifiable skill in the primary care can also be considered. These are the I would recommend all the institution not to come down at any point of time and use all your resources, both from IPS, ITOP, UGs. When the stakeholder meeting is there, do let us know so that all of us can bombard some letters to them to ensure that they don't come down on what is given to us, at least. And wherever possible, to have the mandatory evaluation of outcome. So that is something I would request from this group that we should not come down on it. These are my opinion about UG psychiatries.
Look, I don't think we'll get less than the NMC. The issue is about whether we can get more. The NMC curriculum, the hours and other things the minimum will be met. What Shantanu is trying to get is a bit more than that. I think we should. The points you're raising are good points. I think we should try to incorporate them. One of the logics that I have been trying to push at AIMS, but as you can see, there's a discrepancy between what we try here and what the deans do ultimately, is that in undergraduates, they should, for clinical things, they should teach 5 subjects: medicine, surgery, psychiatry, pediatrics, and obs and gynae. All the other subjects that are taught at undergraduate level now have become very technical, and they need to be taught at MD or MS level rather than at MBBS. Like for ENT, if we want to teach undergraduates ENT, we can only teach them medical aspects of ENT. They can't do surgeries. So there's very little of ENT that they can practically do. So some of those other curricula should become smaller, and that's probably the reason why orthopedics and some of those surgical skills thing is coming down a bit, because undergraduates can't do those things, but psychiatry is something which undergraduates can very easily do. So that is the logic that we are trying to push, that psychiatry should become a bigger subject in undergraduation, because that's something which they can learn easily. It's a clinical field. A lot of skills in psychiatry are clinical rather than having a lot of inputs from technology in that way. So that's one logic that I'm trying to push at AIMS Delhi with limited success. Okay, so other points anyone wants to make?
Sir, so this is Dr. Armud. So it's been an enlightening discussion. I would like to add, like in the attempt to standardize the curriculum across AIMS, the student-teacher ratio should also be kept in mind while we try to standardize across. So that point I would like to add to this discussion. Sir. Thank you.
Sure. Any other points that people want to bring about? Okay, so I think I'll raise some issues which maybe you would want to respond to. It was an interesting discussion, and for undergraduate teaching, I felt that there are differences. Obviously, the different institutions have different models, but I see more similarities than differences. Like it's something like, if you see the IQ of human beings, it may range, let's say, average from 80 to 120, but the IQ of human beings will be different from the IQ of horses, for example, or dogs in that sense. So there are differences of that kind. Most of the, apart from the Deoghar and Rishikesh, which have separate subjects, the rest of AIMS are similar in terms of whether it's 6 weeks of posting or 9 weeks of posting. It's somewhere in between kind of a thing. So with undergraduate curriculum, I think the important thing to kind of focus on is, first thing is that we have to understand that when we are trying to teach people something, that suppose we want to teach English, then we teach English to in play school also, we teach English in primary school also, we teach English at PG level also, and PhD level also. So in that sense, we should be clear about what we are going to teach at each level. And one major issue with undergraduate teaching is that we have to compete with other subjects. The other thing that we have to understand is that if we put all the subjects together, in the NMC curriculum, there are about 5,000 SLOs which people have to master in 5 years. So the number of SLOs that we want to push through should be thought about carefully as to which ones that we want undergraduates to learn. So with undergraduate, we have to be very parsimonious, and we have to compete with other subjects and give our rationale as to why we should get more, at the same time which ones we have. So both these things Dr. Kishore had kind of tried to emphasize, that we should be trying to get more time, but also that with certifiable skills, which priority areas, those things should be kind of emphasized. In some ways, the other point that Dr. Kishore also mentioned, I think is very important, that ultimately we can get more marks in next or INISET or NEET. It will improve the emphasis on undergraduate psychiatry. If we don't get more marks there, even probably a separate paper has less power than next or NEET will have. What is very clear is that the autonomy that each institution had is going away, at least as far as undergraduate curriculum is concerned. In some ways, it was interesting to have these very many different kind of models. And because, like, for example, when Rishikesh came up with a separate paper, all of us have tried to push for a separate paper. So in some ways, this the autonomy of different institutions could have been useful also, but as the things are moving, we see that we will have a uniform AIMS system very soon. We will not have this freedom of doing different things in different institutions. And so putting our efforts together makes sense, because then we'll be able to get a better kind of overall undergraduate deal, so to say. The other side of it is that for PG curriculum, personally, I think we shouldn't rush into having a uniformity right now, in the sense that what I'm trying to raise is that for undergraduate curriculum, we have to go for uniformity because it is already happening. If we don't do it now, it will be too late. For PG curriculum, my suggestion will be that we should go into how to do a curriculum. Like, many of us are talking about curriculum, but we don't really know how to make curriculums. We just go about. Rishikesh has done a relatively good job of how to part of it. Most of the other people just pick up certain things and do it. I'll just give you an. I'll just share. This is the John Hopkins model of developing curriculum, that they first identify what are the problems, what are the general health needs, what are the targeted need assessment, goals and objectives, and so on. The point that I'm making here is only that curricular development itself is now a process. So probably before we start standardizing the PG curriculum, because there is no pressure from any body right now that we should do it. So we should probably go into a scientific way of developing curriculum and then develop it. So we start with how to and then start developing the curriculum. So it can be a kind instead of a one-step process, it will be a two-step process. In that way, we will be able to kind of take into account some of the issues that Aru had just raised, that what are the problems and what are the resources. The Rishikesh model utilize some degree of evidence in curricular development rather than just I think this, I think that kind of a thing. Instead of going by a end date approach that we should have this curriculum ready in 3 months time kind of a thing, I think we should go into the process issues better, so that we develop something which is genuinely robust, and rather than do something and put it together. Because if there is no time pressure, I don't see why we shouldn't do a better job of it, rather than trying to create an artificial time pressure and then trying to meet those requirements. So these are some of the points that I thought I would bring to the discussion, and maybe different people may want to respond to this.
Sir, one of the points in postgraduate psychiatry curriculum which we want to discuss is each institution also has some areas of strength. For example, sleep medicine is very good in AIMS Rishikesh, sir. And for us, let's say in JSS, we are very good in training in sexual medicine. So one of the thought which comes to our mind is, when we are making a curriculum, we should give weightage to those aspects in which the department has a strength.
Yeah,
I think so. Around 20% of the curriculum should be flexible to incorporate what is readily available in those institutions, for which the faculty is ready and for which the student is also keen to take up. That's one aspect of what we think can be done when we consider where to give leverage to those institutions and geographical areas. That's one part. Second aspect of it is that we should give some weightage to the students' interest also when it comes to the external postings. For example, if the student is very keen on forensic psychiatry, we can provide them that 1 month training in forensic psychiatry, which can be used by the student to learn. Or it can be neuromodulation or anything which the department does not have, for which there is a way to evaluate the student after that posting, which becomes part of the curriculum. Because one of the apprehensions institution have is that once they send the student outside, some students do not use that opportunity. They skip the entire external postings. And to make the problem worse, the National Medical Commission also has given away nearly 900 working days of the postgraduates as a acceptable leave. So it really creates problem in some of the areas. So These are the, one is for the institution, we should give some leverage. One is for the postgraduates who have genuine interest. That is also one thing. The third aspect of postgraduate curriculum we should seriously consider is when we continuously add new things, where we should actually cut off. Because neuromodulation has come, artificial intelligence has come, precision psychiatry has come. But if we keep on adding, will it be possible for the postgraduate to do something? So one of the thought is that, can we keep something as must know, something as desirable, because that gives some kind of uniformity in many aspects. These are the thoughts which we have. And I was telling Dr. Aro that there is already a group. We would request everybody to join the group, and we further make the outline of what has been communicated today, and he will make an outline of all the points which people have raised. And we will again sit together and discuss where can we, as you rightly said, which direction we want to have some agreement, where we should give lot of weightage to the institutional requirement. That can also be one of the aspects of discussion, sir. One of the important stakeholder of postgraduate and undergraduate is that we should have representation from undergraduates and postgraduates respectively, because world over the consensus is you should involve them when you are making some aspects of curriculum. So we should have some representatives from the postgraduates in AIMS institution. We should have some representatives of undergraduates in AIMS institution to give us broad insight into what do they think about some of the aspect. This is also a small part of the exercise we have in mind. These are some of the quick ideas, but as you said, we have already have common things which many institutions have agreed. We should see where we can make those customization, and how can that be acceptable model is also some of the points we should discuss. And since most of us are going to Delhi for ANSIP, sir, I would request under your chairmanship, we can again sit together in person there and have little more deliberation. So I would request Dr. Aro to look for all the people who have come here, whether some of them are coming to ANSIPs, and we can sit with Pratap Sharan sir and deliberate on some of the finer aspects of this discussion. These are some of my consideration and opinions, sir. And about those aspects which you have critically evaluated, like psychotherapy, we have considered that it is mandatory for postgraduate training. And as somebody said, whether we can have some online sessions periodically, where postgraduates from these institutions where there are less resources can come, and we can support them in learning, which we can consider as mandatory aspect of postgraduate training. So this is also one of the suggestion I think we should add, not just only on curriculum. How will we do that teaching learning also should be considered. These are a couple of thoughts which come to my mind at this point, sir. Over to you, Dr. Aro.
I'll just respond to 2 points. One is that we have to now see post-graduation like we see undergraduation, because now we are getting DMs and PDFs and all other kind of things. So PG training has to be standardized, where, as you said, at least 80% should be core and 20% could be left optional. And that 80% has to be defined in a careful manner that it is not overwhelming.
Correct.
So it should be something, and which all institutions should be able to provide. So the resources and other things become very important from that perspective. We try to utilize undergraduates in the undergraduate curriculum development. One thing which we found was that they make tougher curriculums than teachers do. That is because usually the people who are called for the feedback, or the people who want to come for the feedback, are the good ones.
Yes.
So when you get feedback, you have to find those students who struggle. So that's a practical kind of a consideration, that find students who struggle to give an opinion about which things to keep and which not to keep, rather than the the ones who are doing well. So that's just a kind of a side thing. I think I'll now hand over to Argo to finally some things up.
Thank you, sir. Thank you, Professor, also for planning and executing this meeting. It was we have I think, sir. You want to? Kishore sir wants to say something. Kishore sir has.
Yes.
Can
He's
I
back.
share, sir, one thought, sir? Can I share one thought, sir?
Yes, please, sir.
In most of the institution, that is also, there is a orientation program also. So we should have one lecture in that also, because in the whenever the MBBS first year or post, there is orientation program in the institution. That is also very beneficial.
Sure.
Kishore sir, I believe you are trying to say something.
No, I was saying that you have a survey.
Yes, sir.
Yeah. Please mention that also, please. Yeah.
Right. The thing that I was saying that we have generated quite a bit of information today, and which is very comprehensive, and I'll try to make some sense out of it so that that can be used and used forward. I'll also shortly post. I'll probably individually forward the link of the survey to all the persons I have contacted in the institutes, and we'll be looking forward to the responses to that survey. Um, and finally, this has been, I believe, a very useful exercise for all of us to gather insight about the situation that is there right now and maybe improve on what we can do in the future. As the kind of organizing chairperson for this meeting, I take accountability of all the mistakes that have been done, and I sincerely apologize for that, and I'll try to make up for the lost opportunities because those are very valuable. With the permission of all, I will now continue the session.
Aro, you have to just click stop recording.
That console is not with me. That is with Minds.
Is the option available?
It's not with me, sir. It's with Minds.
Okay. I'll ask them. Don't close till I tell them.